Cerebro-vascular accidents. We will study subtypes of strokes today, ischemic and hemorrhagic. But before studying strokes, we must study the anatomy of the brain, the vasculature of the brain. We have two brain circulations. One for our cerebral cortex, cerebral circulation, covered by anterior cerebral artery, middle cerebral artery, and posterior cerebral artery. Thus, three cerebrals, this one, and this one. And vestibulo-basilar circulation, the one related to our cerebellum and brainstem. Cerebellum and brainstem. Vertebro-basilar circulation. Two vertebral arteries will join to form basilar artery, and down they give anterior spinal artery. Laterally they give pica and ica. So this covers our brainstem and cerebellum, this area, and this covers our cerebrum. This is a brief introduction for anatomical vasculature. Now, a brief introduction also for physiology. In our middle cerebral artery supplies our lateral brain, while our anterior cerebral artery supplies medial brain. Either lateral or medial brain, there are two important areas, sensory area and motor area of the brain. They start laterally and continue medially. Laterally, look at the brain the body parts presentation in our brain. Middle cerebral artery supplies our face and our hand, while anterior cerebral artery supplies our pelvis, bladder and genitalia, and our legs. Either sensory and motor. As I showed here in this picture, motor and sensory area are adjacent. So affection of middle cerebral artery, I can say that the patient could have sensory or motor abnormalities in his arm and his face, contralaterally. Another patient with damaged anterior cerebral artery, I can say that he could have either motor or sensory symptoms in one leg plus genitalia, as you see here. Middle cerebral artery affection, one arm, in addition half of the face, either motor or sensory, depending on which area in the brain affected, motor or sensory. Anterior cerebral artery, one leg and genitalia, or the bladder affection, he can have urinary symptoms. Okay. In addition, our cerebral cortex has the areas responsible for speech. So lesion will lead to aphasia, neglect. Our parietal lobe, superficial cortex, is responsible for calculations. So losing that, the patient will have acalcula, inability to calculate, agraphia, cannot write, inability to recognize things by touch, in addition to confusion. Those collection of symptoms are called cortical signs. Whenever you see any of those symptoms in addition to motor or sensory abnormality, you should suspect cerebral cortex, anterior middle cerebral artery, cortical signs. And those symptoms will differentiate superficial stroke from deep stroke. Deep stroke, the one supplying brainstem and thalamus. The one supplying internal capsule and thalamus. Then the last one, posterior cerebral artery. Posterior cerebral artery supplies our occipital lobe, the lobe responsible for vision perception, vision illustration, and interpretation. Losing that, the patient will have some abnormality with vision, like visual illusions, inability to recognize people by vision, alexia without agraphia, he cannot read but can write. So mainly things related to vision, and it will be the easiest one to diagnose and answer its questions. So those are cerebral strokes. Now brainstem strokes, but a brief introduction first. Our brainstem and cerebellum, as you know, cerebellar function is balance. So abnormalities affecting cerebellum or the tracts going to cerebellum, like spinocerebellar tract, a tract coming from our spinal cord, or cerebellar peduncles, will lead to ataxia, vertigo, and a loss of balance, sometimes nystagmus. This is cerebellum. What about brainstem? Mainly it has our cranial nerves from 3 to 12, arranged like this. Midbrain has 2 nerves, 3 and 4. Pons has 5, 6, 7, 8. Medulla 9, 10, 11, 12. Those nerves are arranged like this. In the middle, medially, in midbrain, cranial nerve 3, in the pons 6, in the medulla 12. So 3 and it's double 6 and it's double 12. Why is this important? Because this can give me a hint if there is a stroke in brainstem. Where is the artery affected? Is it in medial midbrain or lateral midbrain? Medial midbrain, as we discussed in the anatomical vasculature, it will be basilar artery, anterior spinal artery. Lateral could be pica, could be ica. So it will help me to make a diagnosis. So mainly it contains cranial nerves in addition to some other important tracts, as I will illustrate. So look here, medial brainstem, it will contain things with M letter. Motor nerves like 3 in midbrain, 6 in pons, 12 in medulla. Motor tracts or motor fibers coming from corticospinal tract, and medial meniscus, especially in medulla specifically, carrying vibration proprioception. While lateral brainstem, it will contain things with S letter, sensory nerves, the rest of nerves other than 3, 6, 12. Spinothalamic tract, carrying pain and temperature. Spinocerebellar tract, going to cerebellum, so for balance, and cerebellar peduncle also for balance. Strokes in brainstem will present like this, either cross sign. What's cross sign? One side of the face, other side of the body. One side of the face, the opposite side of the body. If it's sensory, then this is lateral brainstem syndrome. If it's motor, then this is medial medial brainstem syndrome. Okay, you just told me medial, let's say medial brainstem. Okay, how to know? Is it midbrain, medial pons, medial medulla? The cranial nerve will tell you. So your first step in making a diagnosis for brainstem strokes, cross sign. This side and this side. Okay, this is brainstem. Is it sensory or motor? Okay, the patient has motor problem. Then this is medial brainstem. Could be midbrain, could be pons, could be medulla. The third step is looking at cranial nerve sign. If it's, let's say, cranial nerve 3, then we are at medial midbrain. Cranial nerve 12, then this is medial medulla. Then the artery supplying medial medulla is anterior spinal artery. So this is the artery affected. So this is how I made a diagnosis. So this is the first presentation, cross sign. The second presentation, one side of the body plus cranial nerve sign. One side of the body, again, the same rule. Is it sensory or motor? Plus cranial nerve sign. Where is cranial nerve located? Midbrain, pons, medulla. This is how I will make a right diagnosis. Now let's go deeper in our brain. Look, the medial deep cortex. We will find thalamus, as you see here, that big thing, and internal capsule in red color. Deep brain strokes will have absent cortical signs. Remember, no aphasia, no agraphia, no acalculia, no agnosia, all of that. So just motor or sensory abnormality. Motor or sensory. Pure motor, then this is internal capsule. Pure sensory, this is thalamus. And it will be easy to be diagnosed and answered in questions. Same side of the face, same side of the body. Sensory, thalamus. Motor, internal capsule. So same side of the face, same side of the body. Motor, internal capsule, sensory for thalamus. Okay, so we finished the anatomy and pathology of strokes. Now let me tell you about stroke types. We have ischemic stroke and we have hemorrhagic stroke. Ischemic stroke due to thrombi or emboli. Causes are anything leading to atherosclerosis, hypertension, diabetes, smoking. Okay, will lead to atherosclerosis build up, as you see here, and easily a thrombi can come here in this area and occlude the lumen 100%. Or an emboli traveling from a distant place like the heart. A patient with atrial fibrillation, patent foramen ovale. There is emboli inside the heart that traveled into our brain and occlude the lumen 100%. And since it occludes the lumen 100% and suddenly, the patient will have maximal symptoms at the start. Sudden, severe, maximal symptoms at the start. Unlike hemorrhage, as you see here, hemorrhage can be due to hypertension also, especially if the patient is taking anticoagulant, especially if the patient has like vascular abnormalities like aneurysms. Rupture will lead to blood leakage, gradual blood leakage. So the symptoms, unlike ischemic stroke, will be gradual, and that blood leak is associated with high intracranial pressure symptoms like nausea, vomiting, papilledema. Okay, so hemorrhagic stroke is gradual, ischemic stroke is sudden. Now for the treatment. The treatment of each type is opposite the other. Ischemic stroke blood thinners, I will thin the blood. Hemorrhagic stroke, I will reverse the anticoagulant. So a misdiagnosis can kill the patient. If my patient has hemorrhagic stroke and I give him blood thinners, this can increase the bleeding and can kill the patient. That's why I should make a correct diagnosis. Non-contrast CT scan is the best step, is the best initial step. It will allow me to exclude hemorrhage. Look, this is hemorrhage in non-contrast CT scan. It looks white, hyperdense. If I found that hemorrhage, okay, this is hemorrhagic stroke. Ask your patient, do you take warfarin? Yes, I take it. Then reverse warfarin. Give fresh frozen plasma. Do you have high blood pressure? I will lower your blood pressure. Do you have intracranial pressure symptoms, causing nausea, vomiting, and predisposing the brain to herniation? I will lower the intracranial pressure by, let's say, elevating the head, hypertonic saline and mannitol to decrease the brain edema, hyperventilation to wash out CO2 and decrease the fluids in the brain by causing vasoconstriction, and taking the opinion of a consultant who will decide if the patient will need evacuation or not, surgical evacuation or not. This is for hemorrhage. No, the CT scan is negative. CT scan is normal. Then this is ischemic stroke. Ischemic stroke, CT scan is negative. Okay, what to do? Give the patient thrombolytics to dissolve the thrombi in the first 4.5 hours from the symptoms. Check the patient blood pressure. Lower the patient blood pressure lower than 180 over 110. Why? Because if you give a patient with blood pressure higher than 180, if you give him thrombolytics, he will bleed. Okay, so lower the patient blood pressure lower than 180, give him thrombolytics, then do MRI of the brain and even MR angiography sometimes to see the type and location and size of the thrombi. Location and size of the thrombi. Look here, this is the vessel. If you found small thrombi, we can leave it alone. But if we found big thrombi, we must remove it, thrombectomy with a catheter. Thrombectomy to remove the thrombi. After that, we want to correct the patient risk factors, or we want to search the causes of the thrombi to prevent recurrence. Okay, the commonest two causes of thrombi, atherosclerosis. Okay, so we will control atherosclerosis risk factors: aspirin, statin, blood pressure, glucose, smoking, etc. This is for thrombi prevention. What about emboli traveling from another place? It can come from here, carotid atherosclerosis. Then we will image them to see Doppler ultrasonography of carotid. And if there is severe stenosis here, we can put a stent. The second commonest cause, atrial fibrillation of the heart, ECG and echo for the heart to see if the heart sends emboli to the brain, and we can correct the cause. Okay, this is workup and treatment for strokes. Now let us apply in questions. Questions at level of a step 1, they love to ask about anatomy. I will give you the symptoms. Let's say I gave you cross sign and asks you which area in your brainstem is affected. This is most of step 1 questions. For step 2, they love to ask clinical questions like next step will be non-contrast CT scan or giving the patient thrombolytics. If it's hemorrhagic stroke, what will you do? So more clinical application. Let us see here. Which of the following findings is most likely to be observed in the patient? And he has this exhibit, and they are pointing to an artery. This is pica, if you remember. Okay, so I expect him to give me symptoms, and I will. I expect him to ask me about this artery. Let's say he will say this artery is occluded. What symptoms will the patient have? Let's read and see. 64-year-old woman is brought to the emergency department due to stroke-like symptoms. Okay, stroke-like symptoms. The patient has a history of transient ischemic attacks, a risk factor, as well as other risk factors of cerebro-vascular diseases as hypertension, diabetes, hypercholesteremia. Brain imaging reveals occlusion of the vessel in the exhibit. Okay, this vessel is occluded. Let us guess the symptoms. This is brain stem, most probably cross sign, one side of the body, other side of the face. Since this is lateral, it will be sensory affection. Sensory affection. Now let's read and see. Eye symptoms, no. Motor, eye symptoms related to cranial nerve 3, 4. So in midbrain and pons. So this is wrong. Motor, it will be medial. So this is wrong. Okay. Loss of conjugate lateral gaze, cranial nerve 6, which is in pons. This is wrong. Then sensory. Sensory loss over right side of the face, left side of the body. This is it. Right side of the face, left side of the body. This is the answer. Cross sign. Cross sign sensation. This is brainstem. Okay, the second one. Second question. An embolic occlusion affecting which of the following? So in the first question, he gave us the artery occluded and asked for the symptoms. Here, look, they are giving us the symptoms and asking for the artery. Embolic occlusion affecting which of the following vascular regions is the most likely cause of this patient's current symptoms? Okay. A 58-year-old man comes to the emergency department due to 3-hour history of abrupt onset weakness and numbness of the right lower extremity as well as urine incontinence. Oh, remember my picture. Right lower extremity in addition to the bladder affection. So this is anterior cerebral artery, left anterior cerebral artery. Okay, I can exclude answers. Middle cerebral, middle cerebral, middle cerebral. Here, anterior cerebral, anterior cerebral. I'm between those two answers. Anterior cerebral, even without reading the rest of the question. Anterior cerebral artery distal to the origin of anterior communicating artery or proximal to the origin of anterior communicating artery. If you remember circle of Wallace, it was like this. That was the anterior communicating artery. So they are asking, is the occlusion here or here? Remember, the aim of circle of Wallace, that circle is to compensate for any occlusion. If an artery is occluded in the circle, there is anastomosis. Other branches can compensate for the occlusion and no symptoms will appear. So this is if the lesion is inside the circle. If the lesion outside the circle of Wallace, no anastomosis, so no compensation, the patient will be symptomatic. Since our patient here is symptomatic, he has leg symptoms, bladder symptoms, then it will be distal outside the circle of Wallace, distal to anterior communicating artery. Those are step 1 questions. At level of step 2, they will ask us about the steps, clinical steps. Which of the following is the best next step in management of this patient? Next best step. 76-year-old woman is brought to the hospital due to confusion for the past hour. The patient husband says that she started having an occipital headache for the past 2 hours ago and took acetaminophen and went to bed. So started with headache, and then she slept. An hour later, she had difficulty waking up and found her confused. Medical history significant for hypertension and seizure. She took phenytoin, amlodipine, lisinopril. She lives with husband. Okay, temperature normal, blood pressure is high. The patient is somnolent, but responds to painful stimuli and withdraws hair for extremities. She cannot follow commands, mumbles in a few intelligible words. Deep tendon reflexes are symmetric. Babinski is absent. So we suspect stroke. The patient has hypertension. The patient now is somnolent, does not respond. Could be ischemic stroke, could be hemorrhagic stroke, we do not know. So next step is what? Non-contrast CT scan of the head. This one. Non-contrast CT scan of the head. If hemorrhage, as we said, reverse the bleeding, decrease the intracranial pressure, decrease the patient blood pressure. If ischemic, thrombolytics, decrease the blood pressure. Look for the cause of the thrombi and correct it.